Good afternoon, everyone. My name is Laura Morell, and I work in the National Center for Emerging and Zoonotic Infectious Diseases at the Centers for Disease Control and Prevention. On behalf of the One Health Office, I'm pleased to welcome you to the monthly Zoonoses and One Health Updates call on May 5th, 2021. Next slide. Although the content of this webinar is directed to veterinarians, physicians, epidemiologists, and related public health professionals in federal, state, and local positions, the CDC has no control over who participates. Therefore, please exercise discretion on sensitive content and material, as confidentiality cannot be guaranteed. Today's webinar is being recorded. If you have any objections, you may disconnect now. Next slide. Today's presentations will address one or more of the following 5 objectives. Describe 2 key points from each presentation. Describe how a multi-sectoral One Health approach can be applied to the presentation topics. Identify an implication for animal and human health. Identify a One Health approach strategy for prevention, detection, or response to public health threats. And identify 2 new resources from CDC partners. Next slide. In compliance with continuing education requirements, all presenters must disclose any financial or other associations with the manufacturers of commercial products, suppliers of commercial services, or commercial supporters, as well as any use of unlabeled products or products under investigational use. CDC, our planners, presenters, and their spouses or partners wish to disclose they have no financial interests or other relationships with the manufacturers of commercial products, suppliers of commercial services, or commercial supporters. The Planning Committee reviewed content to ensure there is no bias. The presentations will not include any discussion of the unlabeled use of a product or a product under investigational use. CDC did not accept commercial support for this activity. Next slide. Instructions for receiving free continuing education are available at cdc.gov/onehealth/zohu/continuing education. The course access code is OneHealth2021. To receive free CE for today's webcast, complete the evaluation at cdc.gov/TCE online by June 7th, 2021. A captioned video of today's webinar will be posted at cdc.gov/onehealth/2021/may.html within 30 days. To receive free CE for the web on demand video of today's webinar, complete the evaluation at cdc.gov/TCE online by June 8th, 2023. Next slide. Before we begin today's presentations, Nadia Usayev, Acting Deputy Director of CDC's One Health Office, will share some news and updates. You can start when you're ready.
Thank you, Laura. Hello, everyone. Thank you for joining us on today's ZOHU call. We appreciate you being here. Before our presentations, I'd like to share a few One Health COVID-19 updates and highlights from today's ZOHU Call email newsletter. If you're not yet subscribed, please use the link at the top of the main ZOHU Call webpage so you can stay informed. CDC's response to the COVID-19 outbreak continues to evolve. Please check CDC's website for the latest guidance and resources, including information about keeping people as well as pets and other animals safe and healthy. We also hold monthly One Health Partners COVID-19 webinar to provide news, key updates, guidance, and resources for public health officials, animal health officials, veterinarians, and pet owners. The next call will be on May 18th. Please email onehealth@cdc.gov to receive more information on how to join the webinar. Next slide. At this time, CDC is aware of SARS-CoV-2 infections in animals from 25 countries, including cases in companion animals, including dogs, cats, and a pet ferret, in zoo, sanctuary, and aquarium animals, including gorillas and otters, and multiple species of large cats like tigers and lions, in farmed mink, which are counted by the affected farm and not individual number of mink, and also in wild mink captured outside an affected mink farm. Next slide. In the United States, 173 animals have been reported with SARS-CoV-2, including 82 cats, 64 dogs, 23 large cats of 4 species in zoos and sanctuaries.
Nadia, I think people aren't able to hear you. We're getting some messages, yeah, that we can't have.
Can you hear me?
Audio.
Can you hear me now?
We hear you on our end. Can folks hear her now?
Testing, can you hear me?
I think we still aren't getting any audio for you, Nadia. I'm not sure why the presenters can hear you, but nobody else apparently. So I'm happy to read the updates since we're having some audio issues for you, and it seems like people can hear me.
Okay.
Okay.
You can hear me, but they can't. Go ahead.
Okay, hold on just a second, folks, while we go back and we'll start from the beginning. I apologize for that. Okay. Thank you, Sarah. Okay. So we're going to share a few One Health COVID-19 updates and highlights from today's ZOHU Call email newsletter. If you are not yet subscribed, please use the link at the top of the main ZOHU Call webpage so you can stay informed. CDC's response to the COVID-19 outbreak continues to evolve. Please check CDC's website for the latest guidance and resources, including information about keeping people as well as pets and other animals safe and healthy. We also hold a monthly One Health Partners COVID-19 webinar to provide news, key updates, guidance, and resources for public health officials, animal health officials, veterinarians, and pet owners. The next call will be on May 18th. Please email onehealth@cdc.gov to receive more information on how to join the webinar. Next slide, please. At this time, CDC is aware of SARS-CoV-2 infections in animals from 25 countries, including cases in companion animals, including dogs, cats, and a pet ferret, in zoo, sanctuary, and aquarium animals, including multiple species of large cats like tigers and lions, gorillas, and otters, in farmed mink, which are counted by the affected farm and not individual number of mink, and also in wild mink captured outside an affected mink farm. Next slide, please. In the United States, 173 animals have been reported with SARS-CoV-2, including 82 cats, 64 dogs, 23 large cats of 4 species in zoos and sanctuaries, 3 gorillas, multiple otters, and 1 wild-caught mink captured near an affected mink farm. We are also aware of 424 mink farms with SARS-CoV-2 in 12 countries, including 16 affected mink farms in 4 US states. The latest animal case numbers are available on the USDA APHIS website. APHIS also reports confirmed positive animals in the United States to the World Organization for Animal Health, or OIE. Guidance for pet owners, mink farmers, veterinarians, and many others are available on CDC's COVID-19 Pets and Other Animals landing page. Our key messages on animals and COVID-19 as of today are that at this time, there is no evidence that animals play a significant role in spreading SARS-CoV-2 to people. Based on the limited information available, the risk of animals spreading COVID-19 to people is considered to be low, but there is a higher risk for people working on mink farms. More studies are needed to understand if and how different animals could be affected by COVID-19. We will continue to keep sharing timely updates as the knowledge around COVID-19 and human-animal environment interactions evolve. Next slide. Some recent publications of interest include a special collection of articles on the rise of ticks and tick-borne diseases in the Journal of Medical Entomology, which covers a variety of One Health approaches and gaps relevant to tick-borne diseases. Interim guidance from OIE on reducing public health risks associated with the sale of live wild animals of mammalian species in traditional food markets, and national estimates of healthcare costs associated with multi-drug resistant bacterial infections among hospitalized patients in the US. Next slide. Some new web resources of interest include a video of the FDA One Health Symposium held in April. Also, the Epidemic Intelligence Service class of 2022 application period is open through June 11th, 2021. Next slide. And here are some upcoming events of interest, including May being Lyme Disease Awareness Month. And our first presentation today will cover emergency department visits for tick bites. And then this week is National Pet Week. AVMA's website has resources for responsible pet ownership. Next slide. There are 2 new Salmonella outbreaks, one linked to ground turkey and one linked to Jules cashew brie. Please visit CDC's Healthy Pets, Healthy People website for a selected list of ongoing and past US outbreaks of zoonotic diseases. Our next call will take place on June 2nd. Please email topic suggestions for future presentation and news from your organizations to zohucall@cdc.gov. We appreciate your help in spreading the word about the ZOHU Call by sharing the website link with your colleagues from human, animal, plant, environment, and other relevant health sectors, and letting them know about the live webinars, as well as free CE and video recordings of past webinars. Next slide, please. You may submit questions at any time using Zoom's Q&A feature. Please include the topic or presenter's name. The Q&A session will follow the final presentation if time permits. You may also email questions to today's presenters. We've included their email addresses on this slide, on the ZOHU Call webpage for today's webinar, and in today's email newsletter. Next slide. Our first presentation, Emergency Department Visits for Tick Bites, is by Dr. Grace Marks. Please begin when you're ready.
All right, great. Can everybody hear me okay?
I can hear you, yes.
All right. All right, so good afternoon. My name is Grace Marks, as was mentioned. I'm a medical epidemiologist at CDC's Division of Vector-Borne Diseases in Fort Collins, Colorado. And today I'll be talking about emergency department visits for tick bites. I'm seeing some comments that they cannot hear presenter, so I'm going to maybe switch over to my computer and hopefully that will come through better.
Apologies again, people. We are having some more audio issues. She's going to switch over to a different audio source, so just bear with us a moment.
All right, can people hear me now?
Yes, it looks like people can hear you now.
All right, perfect. Okay. All right, so starting again, good afternoon. My name is Grace Marks. Hopefully audio is better now. I'm a medical epidemiologist at CDC's Division of Vector-Borne Diseases in Fort Collins, Colorado. And today I'll be talking about emergency department visits for tick bites. Next slide, please. So as many people on this call are well aware, and as was mentioned actually during the introduction as well, tick-borne diseases are on the rise. Tick-borne diseases account for about 95% of all locally acquired vector-borne diseases, which include diseases transmitted by mosquitoes, fleas, ticks, and lice. Ticks can transmit a number of pathogens, including bacteria, parasites, and viruses that can affect both humans and animals. In the US, the most common tick-borne disease by far is Lyme disease, which accounts for about 70% of all reported tick-borne disease cases. Next slide. This graph shows the 5 most commonly reported tick-borne diseases from 2011 to 2018. Lyme disease, shown in light blue at the bottom of each bar, accounts for most of these reports each year, followed by ehrlichiosis anaplasmosis, shown in green, spotted fever rickettsiosis, shown in red, and babesiosis in gray. A few hundred cases of tularemia are also reported each year as well, shown in dark blue at the top of each bar. Next slide. We know a lot about ticks and the diseases that can occur after a bite from an infected tick. On the left are 3 ticks in the US that commonly bite humans. For each species, the different life stages are shown from left to right: adult female, adult male, nymph, and larva. Most human Lyme disease is caused by the bite of an infected black-legged tick nymph, which is about the size of a poppy seed. A dime at the top right shows just how small these ticks are. Next slide. But even though we know a lot about ticks, there's a lot about tick bites that we don't know. For example, we don't know how many people are bitten by ticks each year, or the healthcare burden of visits for tick bites. We also don't know what the geographical and seasonal patterns are of tick bites, or whether this information might inform public health messaging about tick-borne disease risk and how to prevent tick bites in the first place. Next slide. It's not simple to describe the patterns of human tick bites for many reasons. First, most people likely don't seek healthcare after a tick bite. Even more people might be unaware of having been bitten in the first place. Tick bites are not a reportable condition in and of themselves. And finally, there's no diagnostic codes or ICD codes for tick bite. Next slide. So in 2019, we set about to see if tick bite syndromic surveillance might help to fill in some of these knowledge gaps. We had a series of meetings with the local and state public health partners in areas where Lyme disease is common to discuss syndromic surveillance efforts for tick bites and tick-borne diseases. Many of these states had already been using syndromic surveillance for this purpose and had many helpful insights. We also collaborated with the National Syndromic Surveillance Program, NSSP, and their community of practice members to develop a query to identify emergency department visits for tick bite. This tick bite query identified ED visits with the word tick or tick bite or some combination thereof in the chief complaints section of the note. The full query is shown at the bottom of the slide there. Finally, we designed a novel public-facing data dashboard to track weekly national data. Just last week, we published an MMWR describing our findings after applying this novel query to 3 years of ED visit data in NSSP from 2017 to 2019. In the next few slides, I'll show some highlights from that analysis. Next slide, please. So for this paper, we applied the new tick bite query to emergency department visits at facilities that contribute data to CDC's National Syndromic Surveillance Program, representing about 71% of all the nation's emergency departments. We used BioSense Essence, a national public health surveillance platform that aggregates syndromic surveillance data to explore patterns and trends. Absolute counts and incidence of ED tick bite visits were computed by sex, age group, geographic region, and week and month. Next slide, please. We found that emergency department visits for tick bite are common. During this 3-year period, about 150,000 ED tick bite visits were identified, with an overall incidence of about 49 visits for tick bite per 100,000 ED visits. Next slide. When looking at these data by patient sex, more males than females visited the ED for tick bite. On average, across the 3-year period, each year about 28,000 male patients visited the ED for tick bite, compared with about 21,000 visits by female patients. This is particularly notable given the opposite trend in overall ED visits reported to NSSP during this period, where female patients had over 10 million more ED visits compared to male patients. Next slide. Very young and older people were more likely to visit the ED for tick bite. To orient you to this graph, the number of ED visits are shown in blue, and the incidence per 100,000 ED visits is shown in the green line. Age group in 10-year increments is shown in the x-axis. Compared with other age groups, pediatric patients aged 0 through 9 years of age accounted for the highest number and incidence of ED tick bite visits, followed by patients aged 50 to 69 years. Next slide. Data by the 10 HHS regions, which were the most granular geographic data for which we had access for this analysis, were combined into 5 geographic regions that are shown in the map. Of these regions, ED visits for tick bites were highly concentrated in the Northeast, where risk for Lyme disease is also highest. Next slide. Here you can see the number of ED tick bite visits shown in the y-axis with month along the x-axis. Data in each of the 3 years are shown in the different colors. The seasonal distribution of ED visits for tick bites was consistently bimodal. The larger peak occurred during April through July, and a smaller peak occurred each year in October and November. Notably, this pattern aligns with the seasonality of a known and abundant human biter, the black-legged tick. Next slide. For the next few slides, I wanted to introduce CDC's Tick Bite Data Tracker, the new public-facing dashboard that tracks ED tick bite visits in close to real time. The dashboard includes data from 2017 through the present time, and data are automatically refreshed each week. Take a moment to note the URL at the top of the slide and bookmark it to keep tabs on ED tick bite visit trends in your jurisdiction. Next slide. The dashboard user can filter data by region and by year. In the table on the right, you can see the incidence for ED tick bite visits for all 5 regions. Next slide. This dashboard view shows the incidence of ED tick bite visits by patient sex and age. You can see that the youngest age group, under 10 years of age, is more evenly matched across male and female patients, but that male patients predominate in all other age groups. Next slide. This dashboard view shows the seasonality of ED tick bite visits. The user can toggle between data by month or week, as well as filter by year and region. This seasonality graph can inform when local risk for tick bites is on the rise and can inform the timing of public health messaging. Next slide. Using patterns in emergency department visits for tick bites as a new surveillance tool has several limitations that are worth mentioning. Currently, these data are limited to HHS region, as was mentioned previously. It is notable, though, that this lack of granularity represents a policy barrier, not a technical one. Partnerships with individual states can permit more granular analyses. Second, these data may not be representative of the 30% of emergency departments in the US that currently do not contribute data to the National Syndromic Surveillance Program. An additional limitation is that these data are limited to emergency department visits. People who visit an outpatient clinic or an urgent care center after a tick bite, rather than go to the ED, would not be captured in this system. Similarly, these data may represent healthcare seeking behavior patterns rather than absolute risk for tick bite. Next slide. Despite these limitations, we hope that these data will inform the optimal timing of public health messaging about tick bite prevention, such as personal protective behaviors to prevent tick bites, or how to minimize risk of disease after a tick bite. We also hope that these data will help to tailor outreach about tick-borne disease prevention to those population groups at highest risk for tick bite. Examples might include messaging about Lyme disease post-exposure prophylaxis, or for a future Lyme disease vaccine when it becomes available. Next slide. We plan to continue this work, and we hope that you will be a part of this effort too. This month, we will be reaching out to all state partners to share our findings and to see if they would be willing to contribute their state-level syndromic surveillance data for the next version of the tick bite query dashboard. The goal is to make these data available on a more granular scale to ensure that they're locally relevant and actionable. And finally, we will continue to add additional data visualizations and will increase the functionality of the dashboard too. We'll also be exploring about potentially adding data from other queries for individual tick-borne diseases. Your feedback is critical. Please let us know how we can make the dashboard more useful to you and your program. Feel free to reach out to me directly at lwx1@cdc.gov with any feedback. Next slide. Thanks for your attention, and I'll be happy to answer any questions after the final speaker.
Thank you. Next slide, please. Our next presentation, Trends in Agricultural Triazole Fungicide Use in the United States, 1992 to 2016, and Possible Implications for the Development of Resistant Fungi Causing Human Disease, is by Mitsuru Toda. Please begin when you're ready.
Thank you very much. My name is Mitsuru Toda. I'm from the Mycotic Diseases branch. Next, please. So I'm going to start with a patient story. This is a story about Jan. He lives in the Netherlands and received a kidney transplant a year ago. He loves taking pictures of tulips. Next, please. But one day, Jan was admitted to the ICU with respiratory failure and severe sepsis. He received multiple antibacterials and his condition didn't get any better. Next, please. And Jan was diagnosed with invasive aspergillosis. This is a severe illness caused by mold called Aspergillus. Aspergillus fumigatus is the most common species of Aspergillus that causes aspergillosis. It's a thermotolerant bug, which means that it can live in high temperature like our human bodies. We inhale hundreds of aspergillus per day, but our functioning immune systems protect us from aspergillosis. Next, please. Invasive aspergillosis affects immunocompromised or immunosuppressed people, such as those with cancer, transplant, neutropenia, or who are on immunosuppressive medications. The incidence is projected 0.7% among people who receive solid organ transplants, and the mortality is high, ranging from 25 to 59%. Next, please. Aspergillus-related hospitalizations are really expensive, reaching to $1.2 billion based on analysis looking at insurance claims data. Next, please. But we currently don't have a national surveillance system monitoring the incidence in the general population, so we actually don't know how rare this is. A population-based study projected a yearly rate of 1 to 2 cases per 100,000 population. But this study was done 25 years ago, and the immunosuppressed population is growing as cancer survival increases. An analysis using hospital discharge codes, as seen in the graph here, suggests that the incidence may be rising. And just for a quick comparison, invasive aspergillosis is more deadly than listeriosis and about 5 times more common. Next, please. And aspergillosis is treated with azole antifungals, and triazoles are the first-line treatment. And we only have 3 main classes of antifungals in human medicine. Next, please. Aspergillus can become resistant in the patient body, and this can happen through long-term treatment, typically for those who have aspergilloma or fungal ball in their lungs. And resistance can develop during treatment through mutation of CYP51A gene. Next, please. Triazoles initially reduced mortality since the 1990s, but triazole resistance is now a major problem. Mortality can reach up to 90% for some infections. Next, please. And in a study, survival was actually 33% lower for those who had resistant infections. Next, please. But now there's a new gene mutation that's targeting the 34 base pair tandem repeat, or TR34, in the promoter region of CYP51A. And there's also another one called TR46. Well, we know that Aspergillus disease is not contagious, so the resistant strains wouldn't spread from person to person. Next, please. And the most plausible route of resistant selection in Aspergillus fumigatus is an environmental origin of resistant fungus. We are actually seeing a specific gene mutation in patients who have never received azole treatment, and these isolates can also be multi-azole resistant. Next, please. So now we know that Aspergillus can become resistant in the patient body, but also in the environment. Soil samples from flower beds, compost, leaves, and seeds harbor the specific gene mutation. And it's also been found in patients' homes, backyards, and in air samples in hospitals, and even in sealed tulip bulbs imported from Ireland from the Netherlands. Next, please. And the reason why this is happening is because the azoles that are used as agricultural fungicides, shown in red, such as tebuconazole and propiconazole, exhibit similar molecular structure compared with the medical azoles shown in blue, especially the triazoles that are used for antifungal treatment. Next, please. And this environmentally associated resistant Aspergillus strains have now been reported in multiple countries, including in Europe, Middle East, Asia, Africa, Australia, and South America. Next, please. So going back to Jan, Jan's doctors were able to order susceptibility testing, and Jan received appropriate treatment, and thankfully he survived. And in the Netherlands, they are actually very concerned about this particular resistance, that they have a new guideline to prescribe combination antifungal therapy as first-line treatment for patients suspected of invasive aspergillosis. Next slide, please. But what if Jan was John in the US? Unlike Jan, John likes taking pictures of wheat fields and not tulips. But like Jan, he received a kidney transplant a year ago. Next, please. And one day, John was admitted to the ICU with a similar story as Jan. Next, please. Will John likely be diagnosed with invasive aspergillosis? Maybe, especially given his transplant history. But will John's doctors order susceptibility testing? Next, please. The data suggests no. Only 62% of the infectious disease doctors surveyed through the Emerging Infections Network in the US had access to susceptibility testing. 21% lacked access and 18% were unsure of availability. And for nearly all of those who have access to antifungal susceptibility testing, they're tested through a standout lab and it can take a week or more to return. Next, please. So what about this environmentally associated resistant strain? Is it already in the US? We did a passive surveillance to look for this specific infection in the US, and thankfully we didn't find any back in 2011 and 2013. Next, please. But in 2018, we reported 5 isolates and 2 other with the TR34G mutation in the US, and 4 out of 7 had no prior azole exposure. And because of this, azole-resistant aspergillus is now put on the watch list in the antibiotic-resistant threats report. Next, please. We also found azole-resistant Aspergillus fumigatus strains in crop debris in the peanut field in Georgia, but we only found these cases because we were looking for them. Next, please. So the question that we had was, is there widespread azole fungicide use in the US? Next, please. So we turned to this site by the US Geological Survey that estimated the annual agricultural pesticide use in the US. We looked at the total usage of 15 different azole fungicides and averaged the USGS's high and low estimates. Next, please. The total estimated azole fungicide usage was 428 metric tons in 1992 and stayed relatively flat up to 2005. But you can see that it increased substantially over 400% from 2006 to 2016 up to about 2,880 metric tons. Next, please. And when you look at the geographical distribution of this, in 1992 to 1996 combined, states such as California had higher azole fungicide usage compared to other states in the US. I'll show this map in 5-year increments. Next, please. So this is the map for 1997 and 2001. Next, please. And this is for 2002 and 2006. Next, please. And this one, 2007 to 2011. Next, please. And finally, this is 2012 to 2016. Next, please. So when you compare the first map to the last map, the difference in usage is quite striking, especially in the Midwest and the Southeast. Next, please. And when you look at the graph by crop type, up to about 2005, the major crop type that used azole fungicides were orchards and grapes. But after about 2006, next please, there was a jump in usage of azole fungicides, especially in wheat, corn, soybeans, and other crops. Next, please. And when you look at the azole compound that was used, the most used compound in 2016 were propiconazole and tebuconazole, which are the ones that are structurally very similar to medical antifungals. Next, please. So there are a number of limitations here. We couldn't directly compare fungicide use and azole resistance, and we were not able to adjust the azole usage per crop, arable land, or state-based restrictions on pesticide use. Next, please. However, our main message is that we're really concerned that there was a jump in increase in fungicide use in the US, especially for the azole compounds that are structurally similar to medical antifungal treatments. And azole resistance may be an under-recognized issue in the US or maybe not, but in order to really understand the true scope, we need better surveillance and more susceptibility testing. Next, please. So there's a lot more work ahead. First, we are already doing a pilot with the AR lab network, and we hope that this can give us more information on resistance that's occurring in the US. Second, we think building awareness around this issue would be really important. And third, there may be techniques such as integrated pest management that the agricultural industry could explore further. Compared with medical azoles, the number of different compounds that can be used in agriculture is much greater than in medicine. We definitely don't want to get rid of fungicides, but there may be ways to encourage limited use for medically important fungicides by looking at rotation of crops, doses, and periods of application. And finally, building partnerships with other agencies would be important. And as part of this endeavor, we've already started an informal conversation with USDA and EPA, and we hope that we could come up with a multi-sectorial solution to this issue. Next, please. And here's an infographic and the link to the paper that actually just came out today, which covered the topic of the talk. Thank you. Sorry, next, please. And so to wrap up, we want to thank everyone and just want to emphasize that we know that azoles play a very important role in food production, safety and management, and also in medicine. So it would be really important for public health agencies, academics, industries, and others to come together and to think about solutions to limit the spread of azole resistance. Thank you very much.
Thank you. Next slide, please. Our final presentation, Risks Posed by SARS-CoV-2 to North American Bats During Winter Fieldwork, is by Dr. Jonathan Cook. Please begin when you're ready.
Thank you. And thank you for the opportunity to present to this group today. My name's Jonathan Cook. I'm a research ecologist at USGS. And along with a collaborative group of folks, we've been working to evaluate the risks posed by SARS-CoV-2 spillover from humans to bats. And we're focused primarily on activities that are under the purview of U.S. Fish and Wildlife Service and other natural resources management agencies. And so in going through the talk, I'm going to highlight a bit of the process that we use to do these rapid risk assessments, talk about the utility of experts when we're trying to evaluate the risk of transmission from humans to bats, to inform these unknown parameters for these diseases that we just don't have a whole lot of information on. The fundamental question that was generating this research was whether or not North American bats were at risk of spillover. And there were several reasons to be concerned. The first of which was that the closest known beta coronavirus to SARS-CoV-2 was detected in old world horseshoe bats in Eastern Asia. My presentation is I don't know if there's timing going on. Okay.
Yeah, I think there might be some timing going on there.
Okay, I apologize for that. The second cause for concern is that bats are proficient hosts for a variety of coronaviruses. We know that they have been detected as being hosts for alpha coronaviruses in North America. And then the third cause for concern is that there are many activities that put scientists in close proximity to bats, putting them at risk for exposure to SARS-CoV-2. Next slide, please. And so again, what we did was we pulled together a group of folks early on in March 2020 when there wasn't a whole lot known. And originally what the authors of the report did were to work closely with decision makers to really understand what decisions were immediately necessary and how we might mitigate the risk of SARS-CoV-2 spillover. And so the general steps in the process that they undertook there were absolutely critical to being able to understand the risks, but also provide rapid updates as our knowledge improved, starting with the decision framing. And that's at the tail of that arrow at the top there. Working to really understand what the question at hand is helps us to develop an analytical approach and identify available data to inform risk assessment models, including the identification of key unknown parameters that we may want to rely on expert opinion for to help us provide at least an estimate of the risk, of course, including some uncertainty. And then the results of that modeling effort directly inform the decision and direct policy and research. And finally, as new knowledge is created, we can revisit the decision. And for that first rapid risk assessment, the focus was really on summer activities. Next slide, please. The results of that risk assessment determined a small but non-zero risk of zoonotic transmission, and that those risks could be mitigated or reduced with the proper use of N95 respirators. However, one large uncertainty remained during that early period in March, and that was whether or not bats were susceptible. There just wasn't a whole lot of information out to evaluate the susceptibility of our North American species to SARS-CoV-2, and that's indicated on that figure on the bottom by the lines there encompassing the entire range from 0 to 1. That's the probability of infection. Next slide, please. Moving through the summer months, that first report was foundational for some decisions that were made about summertime activities. But as we moved into the fall, the nature of work that happens with bats changes. Field crews are now entering caves, hibernacula, and field roost sites with large congregations of bats. And so what we needed to do was provide an updated risk assessment that evaluated the risk of zoonotic transmission during winter field work when crews are entering caves and potentially handling bats and just general activities in close proximity. Next slide. And I'm sorry about those timings. Just to highlight again the value of this initial framing, it identified areas where new knowledge was necessary. And several lines of evidence that we used in that update in the fall was a few bat challenge studies that were completed, one of which was on the big brown bat, which is a focal species of that second risk assessment, and also on the fruit bat. The big brown bat study showed that in a small sample size that there weren't viable infections experienced in big brown bats as a result of a viral challenge. We also had information on ACE2 binding and homology, the role that the surface proteins play in cell entry and how that might give us some idea on species susceptibility. We learned about the importance of aerosolized transmission in humans, how the majority of human viral shedding happens through respiration. And so that gives us an indication that enhanced PPE will be quite effective at reducing exposure to bats. And finally, we got more information or new knowledge about the survival of the virus outside of infectious humans on things like cave surfaces or the physical body of bats. Next slide, please. However, we had to revisit the question from the spring of the susceptibility of bat species. Given this new information, we reconvened an expert panel because we had no direct challenge studies on several species that we were interested in. We asked experts to help integrate the new knowledge and use their expertise to reevaluate the susceptibility of bats. And that's indicated on the bottom of that slide in the blue box. And what experts assessed during the second elicitation was that the probability of susceptibility for the 3 bats that we focused on was quite low, with the majority of the density of that relationship falling below 10%. So pretty low probability that bats were susceptible. But again, non-negligible. There is a potential risk of bats being susceptible to SARS-CoV-2. Next slide, please. And so we incorporated all of this new knowledge into a mechanistic risk model that evaluated several key components of the sort of the transmission pathway that we might anticipate occurring during winter fieldwork. The first step in that process was evaluating the emission of virus by an infectious human, how much virus is being shed by a human. And then we can use that amount of virus that was shed to model the exposure that a particular species is getting within a hibernacula or field roost site. And finally, from that exposure, we can use dose-response relationships to evaluate the probability of bat infection. Next slide, please. And because we were working really closely with decision makers, we can use their management alternatives to evaluate whether or not different actions might be effective at mitigating that risk. In particular, the hierarchy of controls that ranges from complete elimination of activities that might put humans in close contact with bats, but also more, I guess, more targeted type approaches that still allow humans to conduct critical research activities, but that lowers the risk. And here I'm talking about administrative controls, which in our case, we considered COVID-19 testing before entry into a cave or hibernacula, and the use of enhanced PPE such as N95 respirators. That's that red, sort of the tip of that pyramid at the bottom there. And the particular controls correspond to the colors on the conceptual model in the middle of that slide. Next slide, please. And so getting at the fundamental questions, how risky is winter fieldwork given that infection risk model and what we know about, or what we've learned about the potential transmission of SARS-CoV-2. And so I'm just going to show a few scenarios that we evaluated. However, the model is quite flexible to different inputs and outputs, and so we can customize our output depending on what the needs of the particular survey might be. Here I'm going to be showing the species-specific infection risk as a function of cave volume and COVID-19 prevalence. Next slide. On the left-hand side of the slide there, I'm showing results for the Mexican free-tailed bat, which was evaluated to be the most susceptible species out of the three that we looked at. On the x-axis are different cave volumes that might be sampled as a result of research activities in the winter. And on the y-axis is the probability that greater than one bat is infected during any one fieldwork excursion. And so we simulated this a bunch of times. We did repeated runs of our infection risk model to look at what the probability of infection might be. And what we saw was that in very tight enclosed spaces, the risk of greater than one bat being infected was about 0.3%. And that dropped pretty precipitously in larger spaces in a nonlinear fashion. Next slide. Oh, go ahead, thank you. We can also produce results again for the little brown bat and the big brown bat, depending on the needs of the agency decision maker and the fieldwork activities that are being planned. Next, we looked at COVID-19 prevalence in the local community of humans, and we evaluated around a range of values that we've observed within populations, ranging from about 0 to 5% local COVID-19 prevalence. And we saw a positive linear relationship between COVID-19 prevalence and the probability that greater than one bat is infected. At 5%, the probability is about 0.1%. Next slide. Digging in a little bit deeper into the activities that scientists might be doing in field during these field excursions, we looked at risk as a function of the number of bats handled, because frequently researchers are handling bats trying to come up with mitigation strategies for white nose syndrome outbreaks. And so that requires close contact, sometimes swabbing the individual bat and assessing body condition. And so we wanted to evaluate the risk of those types of activities. And the y-axis stays the same on this figure. And we looked at across a range of the typical number of bats that are handled 0 to 50. And we saw that there was a positive relationship. However, the risk of this particular activity was lower than the overall risk of just entering the cave and sharing an enclosed space with bats. And that's because these activities are typically on short time scales. An individual bat is only handled for a few minutes. And so the magnitude of exposure is quite low relative to cave entry and the entire fieldwork excursion. Next slide. How effective are mitigation measures? We evaluated both surgical masks in this case because we wanted to identify a mitigation measure where field crews can actively gather the materials necessary to mitigate risk. N95 masks were at some limited supply during this assessment. And we looked at COVID-19 prevalence. COVID-19 pre-survey testing. And what we found was that both measures were actually quite effective at reducing the risk, 65 to 88% risk reduction with masks or pre-survey testing. And that's indicated by those thinner lines below the thick line on all three of those figures. Testing was slightly less effective than the surgical masks. However, in combination, they were both quite effective strategies. And I should mention that we also looked at the effectiveness of these measures in white nose affected populations, which had an overall elevated risk because of the suppression of the immune system that has been observed in bats with active white nose syndrome. Next slide, please. For key takeaways, we found that overall there was a low risk of zoonotic transmission of SARS-CoV-2 from scientists to bats. And the personal protective equipment lowers that risk. Without precautions, there's an estimated 1 in 1,000 chance of infecting one bat during a winter survey, based on some assumptions of that model. With face masks or COVID-19 testing, we found that the risk of transmission can be reduced between 1 in 10,000 and 1 in about 3,300. And finally, although the risk is low, the consequences are potentially significant, making the decision about whether to proceed with fieldwork or any human-bat interaction a complex one. There are a lot of considerations that go into that decision. Next slide. And finally, I just would like to circle back and highlight the value that we found in applying a decision theoretical framework for doing this risk assessment. Because it was able to produce decision relevant results really quickly, because we had that dialogue with agencies that were making these decisions, we were able to develop models that provided them with answers that they needed to proceed with their decision-making processes. We were also able to identify effectiveness of mitigation measures that were practical for the agencies that were involved. And as part of that, we identified key unknowns for future research and incorporated this new knowledge to improve our understanding and estimation. And these processes are ongoing as these recurring decisions continue to be revisited by our agency decision makers. Last slide, please. And with that, I would just like to acknowledge all of the folks that we worked with on these risk assessments. It was really a wonderful team of experts and agency steering committee members, and many others that we relied on along the way. Thank you.
Thank you, and thanks to all of today's speakers for their informative presentations, and apologies again for the technical issues we've experienced today. So we do have time for a few questions. Please use the Q&A feature in Zoom to send your questions, and please include the presenter's name or topic with your question. And we do have a few questions. We'll start with Dr. Marks. Will the tick data tracker include urgent care and family practice data on tick bites one day?
Thanks for that question. It's a really good question. We started with emergency department data because that's the data that is most reliable in the National Syndromic Surveillance Program. It's also the most comprehensive. However, there is a stream of data in NSSP from urgent care centers. So that would be the next space that we would be exploring next. Family clinics would be a little bit more challenging to do at this point, just because of lack of that data stream being available in the platform that we're using. I should say too that it would be a lot easier if we had an ICD code for tick bite. Currently, there's arthropod bite, which is much more broad. So hoping that in the future, as a tick bite specific code becomes available, and as additional data streams come on board, we would definitely be interested to look in that space as well.
Thank you. The next question is for Dr. Toda. Can A. fumigatus be transmitted via the foodborne route in humans?
Yes, thank you for that question. Yes, it possibly could, and I think there are a few publications on that, but we think that the magnitude is much smaller in that realm.
Thank you. And there's another question for you as well. How is the risk of azole resistance to humans from environmental sources of azole use determined, and are there plans to do a risk assessment as part of future work?
Yes, thank you. So we can look at the environmentally associated resistance by looking at the specific gene mutation, the TR34 and TR46 that was shown in the presentation today. And in terms of future work, yes, we think that there is a great opportunity for us to intervene now in the US, because we're only seeing a few infection as of now, but bear in mind that we haven't really looked at this extensively. So I think the next steps for us is to really look at both human and environmental surveillance to be able to detect this in a wider scope. And in parts of Europe, some of the infections are now up to 20% of the 20% of the infections are now resistant. So we don't want to get into that situation. So I think there's opportunities for us to look at this in an interdisciplinary way. Thank you.
Thank you. And another question for Dr. Marks. How different is the tick data from case-based surveillance on age, sex, timeframes, et cetera?
Yeah, it's a fascinating question. Thank you, Connie, for that question. It's something that we're actively exploring. We have a manuscript that we're working on currently, looking at kind of the correlates between the tick bite data and Lyme disease case surveillance, again, looking at those specific factors that you mentioned. So far, it does look fairly tightly correlated. Of course, there are major limitations using tick bite data as an indicator of tick-borne diseases. We're not, of course, able to be specific about what types of ticks we're capturing when we look at just kind of a generic tick bite visit in the emergency department. But it is perhaps an early indicator that we might be able to look at to get a sense about how much tick-borne disease we would be expecting to see in that year.
Thank you. We're almost at the top of the hour. If you have other questions for today's presenters, we have included their email addresses on this slide. They're also on the ZOHU Call webpage for today's webinar, and they're in today's email newsletter. And a video of today's webinar will be posted within 30 days as well. Next slide, please. So please join us for the next ZOHU Call on June 2nd, 2021, and thank you for your participation. That ends today's webinar.